Welcome to the March 2018 podcast from the Journal of Bone and Joint Surgery. This month, our podcast features abstracts of 4 scientific articles published in the March issues of the journal, as well as commentaries by Dr. R. Frank Henn III on the article entitled Teaching Patients How to Reduce a Shoulder Dislocation, a randomized clinical trial comparing the Bos-Holzak-Motter self-assisted technique and the SPAZO method, and Dr. Robert M. Campbell on the article entitled, Does Vancomycin Powder Decrease Surgical Site Infections in Growing Spine Surgery? A Preliminary Study. Be sure to check out this month's Current Concepts Review article, Patient-Reported Outcomes in Orthopedics by the Motion Group. Patient-Reported Outcomes, PROs, assess a patient's perspective of health, function, and quality of life associated with health conditions and medical interventions. PROs offer a unique format to the clinician for understanding the impact of medical conditions or interventions and, as a result, may improve the care provided. In this article, the authors review PROs that are relevant to orthopedic healthcare value, the basic constructs of PROs, the clinical benefit of PRO data, barriers to implementation, and the future direction of PROs in orthopedics. In this issue, JBJS.org presents a new image quiz, a 29-year-old woman presenting with a hand mass. Be sure to visit us online to access these features, as well as the full text of the scientific articles you are about to discover in the following podcast. Next, you'll hear the first abstract of 4 that are being presented in this podcast. This abstract is from the article entitled Teaching Patients How to Reduce a Shoulder Dislocation, a randomized clinical trial comparing the Bos-Holzak-Motter self-assisted technique and the SPAZO method by Dr. F. A. Marcano Fernandez and Associates. Investigation performed at Parc Taulí Hospital, Universitat Autónoma de Barcelona, Sabadell, Spain. There are many different techniques for reducing acute anterior dislocations of the shoulder, and their use depends on surgeon preference. The objective of this study was to compare the pain experienced by a patient performing a self-reduction technique with the pain felt during a reduction performed by a trained physician. The study was carried out at the emergency department of a tertiary referral center. Patients between 18 and 60 years of age with an acute anterior shoulder dislocation were randomly allocated into 2 groups. In one group, the emergency doctor actively guided the reduction process with the SPAZO technique, SP group, and in the other group, the patient used the Bos-Holzak-Motter, also known as Davos or Aranen, self-reduction technique, BHM group. The pain experienced by the patient during the reduction was recorded by means of a visual analog scale ranging from 0 to 10. Other recorded data included demographic characteristics, reduction time, and success rate. Of 378 patients assessed for eligibility from May 2015 until February 2017, 197 did not meet the inclusion criteria. 58 met exclusion criteria, 22 declined to participate, and 41 withdrew before randomization. 60 acute anterior shoulder dislocations were randomized into the SP group or the BHM group. The BHM group experienced significantly less pain during reduction than the SP group, with mean pain scores of 3.57 and 5.26 respectively. No significant difference between groups was found with respect to reduction time or success rate. Conclusions. The self-reduction technique results in less pain than and is as efficient in achieving reduction of anterior shoulder dislocations as the SPAZO technique. These findings favor the use of the self-assisted method as an effective first-line treatment for shoulder dislocations seen in the emergency department, as well as its use by patients with recurrent dislocation. Next, you'll hear a commentary by Dr. R. Frank Henn III on the article entitled Teaching Patients How to Reduce a Shoulder Dislocation, a randomized clinical trial comparing the Bos-Holzak-Motter self-assisted technique and the SPAZO method.
This is Dr. R. Frank Henn III providing commentary for the March 2018 JBJS podcast. I will be providing commentary on the article entitled Teaching Patients How to Reduce a Shoulder Dislocation, a randomized clinical trial comparing the Bos-Holzak-Motter self-assisted technique and the SPAZO method. The title of my commentary is You Can Do It! Directed Self-Reduction of an Anterior Shoulder Dislocation Works. Many techniques for reduction of an anterior shoulder dislocation have been reported. Given the frequency of these injuries, it is important to establish the most effective, safe, reliable, and economical method of reduction. We commend Marcano Fernandez et al. For their potentially landmark randomized trial comparing the Bos-Holzak-Matter, or BHM, self-reduction technique and the SPAZO, physician-performed technique. The Bos-Holzak-Matter technique is also referred to as the Davos technique, but we recommend calling it the BOSS technique to facilitate teaching and recollection. There have been few Level 1 studies on shoulder reduction techniques, and we are not aware of any randomized studies on the BOSS self-reduction technique. Amar et al. Conducted a randomized clinical trial that showed that the Milch technique was superior to the Stimson technique with regard to success rate and time to reduction. In their randomized clinical trial, Saeg et al. Found that the new fast, reliable, safe, or FAIRS method to have a significantly higher success rate than the Hippocratic and Coker methods, as well as a shorter time to reduction and a lower visual analog scale for pain. Alkodahimi et al. Systematically reviewed 7 additional randomized trials and found that prone scapular manipulation was the most successful, fastest, and least painful technique. They also found that the overall success rate was 92% with the FAIRS method and 89% with the SPAZO technique. Of note, none of these studies included in the review were performed in the United States. The current studies show that the BOSS technique, performed under the guidance of an emergency room physician, was safe and effective and caused significantly less pain than the SPAZO method. There were no significant differences in the rate of successful reduction, but the trend favored the BOSS technique. The mean time to reduction was similar for both methods. There is some concern about confounding variables given the high rate of recurrent dislocations and the significant difference in the mean ages of the two groups. The authors controlled for these potential confounders with multivariable linear regression analysis and did not find them to be significant predictors in their model. The potential advantages of the BOSS technique are considerable. Self-reduction could substantially decrease healthcare demands and costs, and patient participation in his or her care could decrease anxiety and improve satisfaction. This technique can easily be translated to the athletic venue or other pre-hospital settings with minimal training. Furthermore, many shoulder dislocations occur in younger patients, and the youngest of these are most at risk for recurrence. After a patient learns to self-reduce a shoulder dislocation, it seems highly likely that he or she would be able to be a boss and perform this maneuver without guidance should there be a recurrence. Educating the patient about the need to follow up with a physician after any recurrent instability event seems appropriate. In previous studies of the BOSS technique, Cerrone et al. Found a 60% success rate without sedation, and Staphylakis et al. Demonstrated an 86% success rate with some patients receiving sedation. These success rates are reasonably consistent with the success rate of 77% without sedation in the present study, and no complications have been reported with the BOSS technique to our knowledge. While the success rate of 77% is lower than the reported 92% rate with the FAIRS technique and the 97% rate with the prone scapular manipulation, the benefits of a self-reduction technique may outweigh a lower success rate as a first-line method. Further work should be done to evaluate the efficacy of the BOSS technique in other patient populations and settings, as well as to follow patients over time.
Next, you'll hear the second abstract of 4 that are being presented in this podcast. This abstract is from the article entitled Red Flags for Low Back Pain Are Not Always Really Red, a prospective evaluation of the clinical utility of commonly used screening questions for low back pain by Dr. Ajay Prekumar and Associates. Investigation performed at Emory University, Atlanta, Georgia. Low back pain has a high prevalence and morbidity and is a source of substantial healthcare spending. Numerous published guidelines support the use of so-called red flag questions to screen for serious pathology in patients with low back pain. This paper examines the effectiveness of red flag questions as a screening tool for patients presenting with low back pain to a multidisciplinary academic spine center. The authors conducted a retrospective review of the cases of 9,940 patients with a chief complaint of low back pain. The patients completed a questionnaire that included several red flag questions during their first physician visit. Diagnostic data for the same clinical episode were collected from medical records and were corroborated with imaging reports. Patients who were diagnosed as having a vertebral fracture, malignancy, infection, or cauda equina syndrome were classified as having a red flag diagnosis. Specific individual red flags and combination of red flags were associated with an increased probability of underlying serious spinal pathology, e.g., recent trauma and an age of greater than 50 years were associated with vertebral fracture. The presence or absence of other red flags, such as night pain, was unrelated to any particular diagnosis. For instance, For patients with no recent history of infection and no fever, chills, or sweating, the presence of night pain was a false positive finding for infection greater than 96% of the time. In general, the absence of red flag responses did not meaningfully decrease the likelihood of a red flag diagnosis. 64% of patients with spinal malignancy had no associated red flags. Conclusions. While a positive response to a red flag question may indicate the presence of serious disease, a negative response to one or two red flag questions does not meaningfully decrease the likelihood of a red flag diagnosis. Clinicians should use caution when utilizing red flag questions as screening tools. Next, you'll hear the third abstract of 4 that are being presented in this podcast. This abstract is from the article entitled, "Does Vancomycin Powder Decrease Surgical Site Infections in Growing Spine Surgery?" A preliminary study by Dr. George H. Thompson and Associates. Investigation performed at Rainbow Babies and Children's Hospital, University Hospitals Cleveland Medical Center, Case Western Reserve University, Cleveland, Ohio. Vancomycin powder has been demonstrated to be safe in children, and yet there are no data on its use to reduce surgical site infections, SSIs, in surgery for early onset scoliosis. The authors performed a retrospective study of their patients treated for early onset scoliosis in the period of 2010 to 2016. In 2010, the authors updated their standardized perioperative growing spine care path. The only later change was the gradual introduction of intra-wound vancomycin powder. Procedures were categorized into either the control group without vancomycin powder or the experimental group with vancomycin powder, with otherwise identical perioperative management. Initial insertion, revision, and lengthening procedures and final fusions were included. The authors compared the rate of postoperative SSIs per procedure between the groups. 36 patients who underwent 191 procedures met the inclusion criteria. The clinical and radiographic data were essentially the same between the groups. During the study period, 14 of the 36 patients developed one or more deep SSI. Only 2 patients had multiple acute infections. There were 87 procedures with 12 infections in the control group, while there were 104 procedures with 5 infections in the vancomycin group. The difference in the SSI rate per procedure was significant. The number of individual procedures needed to be performed using vancomycin to prevent an SSI was 10.9. Conclusions. The use of vancomycin powder in growing spine surgery for early onset scoliosis is associated with a significant decreased risk of SSI. It appears to be effective even when previous surgeries have been performed without its use. Next, you'll hear a commentary by Dr. Robert M. Campbell on the article entitled, "Does Vancomycin Powder Decrease Surgical Site Infections in Growing Spine Surgery? A Preliminary Study."
This is Dr. Robert M. Campbell providing commentary for the March 2018 JBJS podcast. I will be providing commentary on the article entitled, "Does Vancomycin Powder Decrease Surgical Site Infection in Growing Spine Surgery? A Preliminary Study." The title of my commentary is "Prophylactic Intra-Wound Vancomycin Powder. Is it a fait accompli?" The use of vancomycin powder prophylactically in the spine surgery wounds began in earnest after Sweet et al. Demonstrated in 2011 study that the addition of 2 grams of intra-wound vancomycin powder to traditional intravenous antibiotic prophylaxis reduced the rate of deep wound infections following thoracolumbar fusions. Since then, the use of topical vancomycin powder placed directly over the instrumentation and bone graft has gradually become accepted as a new standard of care in spine surgery. That seems a reasonable approach to enable further reductions in surgical site infections, a commonly accepted indicator of the quality of surgical care. Thompson et al. Present their early experience with vancomycin powder use in growing spine surgery among pediatric patients, including those treated with growing rod constructs and the vertical expandable prosthetic titanium rib devices, both of which require repetitive surgeries and are associated with a relatively high rate of postoperative wound infection. All 36 patients in the retrospective analysis from the author's institution underwent growing spine procedures between 2010 and 2016 and were followed for a minimum of 90 days after each procedure. At this institution, one provider coordinated the care of all patients according to a standardized growing spine surgery care pathway. Surgeons at this institution began adding the use of inter-wound vancomycin powder to their SSI prevention protocol for growing spine surgeries in 2011. Use was initially at the individual surgeon's discretion, with some surgeons adopting it early and others later. A 2013 report found that the use of vancomycin powder in the pediatric population was safe. Growing spine patients undergo multiple surgical procedures through the course of their treatment and are at great risk of infection than of those of the general pediatric orthopedic population, with an increasing risk of infection with each subsequent surgery. The 36 patients in this cohort underwent 191 surgical procedures during the study period. The authors created a relatively balanced cohorts and compared the proportions of cases that were complicated by infection. The authors found that 13.8% of the procedures in the control group, where there was no vancomycin powder, were complicated by an infection, compared to 4.8% of the procedures in which vancomycin treatment group was given. This difference was significant. As with any observational studies, it is difficult to conclude whether vancomycin powder decreased the rate of SSI or if vancomycin powder was associated with a decrease due to some secular trend, confounding variables, or even detection bias. However, the authors of this study limited many of the potential sources of bias by adding vancomycin powder to surgeon protocols over time. The decision was not based on perceived patient risk factors. Although a single institution study will have a smaller sample size than will a multi-institution or database study, limiting the study to a single institution with a standardized protocol does further reduce the possibility of bias or confounding factors. Infection may not be the greatest surgical risk in these complex cases with early onset scoliosis, but infection is one of the more common complications and may be one of the costliest overall. Furthermore, many of these patients are poor surgical candidates, and any physiologic insult can be life-threatening. Investigation of any means to decrease the infection rate in this population is therefore an important contribution to the care of these patients. The authors present a reasonable analysis of their data that represents the real world of heterogeneity and patient-specific treatments in growing spine surgery, and the authors' analysis of their experience at their institution may be the best representation of what other surgeons may be expected if they add vancomycin powder to their own protocols. The authors present the best evidence possible regarding the association between perioperative infection rates and vancomycin powder administration in growing spine surgery, notes further bolstering the widespread acceptance of topical vancomycin powder prophylaxis in both adult and pediatric spine surgery.
Next, you'll hear the last abstract of 4 that are being presented in this podcast. This abstract is from the article entitled Effective Postoperative Mechanical Axis Alignment on Survival and Functional Outcomes of Modern Total Knee Arthroplasties with Cement, a concise follow-up at 20 years by Dr. Matthew P. Abdel and Associates. Investigation performed at the Mayo Clinic, Rochester, Minnesota. The authors previously compared the 15-year survivorship of total knee arthroplasty, TKA implants, that were mechanically aligned compared with those that were outside that range and considered outliers. The original publication included 398 TKAs performed from 1985 to 1990. At the time of follow-up in the previous study, 138 patients had died and 59 knees had been revised. Since that publication, 49 additional patients have died. At 20 years, 57 of the 292 knees in the mechanically aligned group had been revised compared with 16 of the 106 knees in the outlier group. Postoperative alignment within 0 degrees plus or minus 3 degrees of the mechanical axis did not provide a functional advantage at 1, 5, 10, 15, and or 20 years postoperatively, as demonstrated by the Knee Society scores being similar between the groups. At 20 years, the authors once again did not find that neutral mechanical alignment provided better implant survivorship than that found in the outlier group. Thank you for listening to this JBJS podcast. Please visit www.jbjs.org for commentary and perspective on many of the articles presented in this podcast, and for more content of interest.